Module 6, Part 1, Impact on Populations Disproportionately Impacted by the Crisis. And in Part 1, we will be talking about vulnerable populations. So disasters and vulnerable populations. We can look at our vulnerable populations in many different categories. I've listed several here. Race, language barriers, age, social class, gender, income disparity, disability, foreign birth, victims of war, homeless, domestic violence, are they literate? Any one of these or several of these, quote, classifications, end quote, can really make an impact during a disaster. We know that disasters discriminate. And when we look at our vulnerable populations and the community response. So think about this. A measure of the strength of a community's response is how well they address the vulnerable citizens, the children, the frail elderly, and the impoverished and disenfranchised. And we will be talking about each one of these populations. There are inequalities in access to resources, capabilities, and opportunities systematically disadvantage certain groups of people. We can certainly see that through the coronavirus pandemic we are now experiencing. Disasters that involve water are most significant in terms of mortality. Disasters that involve earthquakes and high winds show more injuries than deaths. And both of these types of disasters often cause displacement, which includes the need to house and feed. And those most vulnerable end up suffering more. So children are especially impacted as they experience damage to their homes, possessions, malnutrition, may have lost parents, grandparents, siblings. Seeing parents or caregivers undergo extreme stress, neglect, abuse, psychological harm, and breakdowns in their social networks, disruption of education. Even those that aren't our most vulnerable children have certainly felt it through the coronavirus. But think about children in better situations that have access to computers so that they can continue their online learning, even though for, say, a kindergarten or first grade, it may be quite difficult, compared to a parent that has no computer, may have one smartphone in the house and 5 children that are trying to learn off of that one smartphone, as long as they have connectivity. Or they don't even have that. So the frail elderly. So I put some examples up here. The Chicago heat wave of 1995 claimed 739 lives, all low income, because they didn't have air conditioning. Many were elderly and lived alone and weren't discovered till later. 2011, the earthquake and tsunami in Japan. 90% of those who died during that event following months were seniors over the age of 70. Yet, seniors only made up 25% of the population at that time. The elderly who have one or more chronic health condition, it could be hypertension, heart disease, diabetes, respiratory issues, the level of vulnerability increases by undermining their ability to prepare, respond, and recover. So if the health systems are also affected, their ability to provide care and support also diminishes. And the elderly often do not want to leave their homes and may also be alone at the time of a disaster. Homebound, socially isolated, mobility impaired seniors may also have difficulty recovering from a disaster. So let's also look at housing and homelessness. And this is an area that I spent 6 years of my career working on in Pinellas County, where I live. It's a county of 1 million individuals. It's part of the greater Tampa Bay area. And we have a significant homelessness situation here, probably in large part due to our climate. You can live outdoors year-round here. Low-income persons are more likely to live in homes that are more vulnerable to the impact of a disaster. Material losses, the damage, destruction due to older homes or poor construction, living in floodplains or along levees, as we saw in New Orleans, areas with excessive heat and drought, and an economic loss. They have no savings to deal with any impact a disaster has. And their health and education is also at greater risk. And they have that inability to obtain and receive aid. No understanding of the bureaucratic systems needed to obtain aid, getting to the centers to actually apply, no childcare to take time off to apply. And so what happens to health? Depression, anxiety, distress, PTSD, and your physical health ends up being compromised. So why do pandemics hit the elderly so hard? Well, remember, viruses aren't picky, and although all age groups are at risk of contracting COVID-19, older people face significant risk of developing severe illness. The physiological changes that come with aging and the potential underlying health conditions, the immune systems weaken. And 95% of the deaths with this particular pandemic have occurred in those aged 60 plus. And so why do pandemics hit the poor so hard? Well, most pandemics begin with a pathogen leaping from wild or domesticated animals to humans, what's called a zoonotic spark. In poor countries, isolated outbreaks smolder, go undetected longer, and spread. Even once vaccines become available, they are likely the last to receive them. Health conditions are not evenly distributed through the population. There are more issues with those who have less education, less money, less access to health care. In a situation like COVID-19, those businesses that require face-to-face, such as at restaurants, bars, retail stores, those all have many low-paying jobs, and those jobs are the ones being lost. Think about, from your own experience, the shutting down of bars, gyms, restaurants, you name it, at the beginning of COVID-19. And those poor people that worked in those establishments lost their livelihood. Now, granted, the government tried to give a little bit of assistance, and hopefully a lot of states gave some assistance, but they've lost their jobs. So how disasters and pandemics impact these populations? Often the vulnerable cannot get out of harm's way. And after the initial disaster, there are the basic needs of housing, food, and medical care. Then comes isolation, depression, inability to connect with resources that may, in fact, be available. So let's look at a couple of examples. Hurricanes Katrina in New Orleans and Hurricane Irma. So Katrina, 30% impacted, had disabilities. Katrina in New Orleans, there was moderate wind damage, extensive flood damage due to levee breach submerging 80% of the city with floodwaters. A very substantial Black population lives in New Orleans, and there's a lot of racial segregation. The Black poverty rate at that time was 35%. Almost all extreme poverty neighborhoods, predominantly Black, and those neighborhoods bore the brunt of the disaster. And poverty. You need money to get through a disaster. And there were also many single-family households, loss of shelter, loss of access to food and diapers and water. And then we had Irma. It struck Florida twice with a very large wind field. 73% of our electricity customers within the state of Florida were left without power for varying amounts of time. I know that we had no power for 1 week, but we could get out of the house. We had a small generator that could at least keep our refrigerator going, and we had access to the stuff we needed. Miserable, yes, but access. $50 billion in damage, Florida's costliest. Of note, a nursing home that flooded, staff left, residents sat in water. I believe we've given you some reading on that particular item. 12 deaths. Next example, COVID-19 in Meridian Manor. This was a senior living facility in Wayzata, Minnesota that had a robust, proactive plan for staying safe during COVID and is owned by Transforming Age of Seattle, Washington, where the first deadly outbreak occurred in a nursing home. They were evacuated after 21 of 59 residents tested positive. 2 died from complications and 13 employees tested positive. This place will not be reopening. So, why does solving health issues for all elevate public health? When I was in my public health capacity, I was asked this question all the time. Why are we focusing so much on the homeless? Why are we focusing on so much on those that don't have any health insurance? The community health intersects healthcare, economics, and social interaction. And community health impacts everything: educational achievement, safety and crime, your ability to work, your financial health, life expectancy, and even happiness. If you live in a non-healthy community, what does that do to your community's health? So it's a complex problem, and it can include exposure to crime and violence starting at very early ages. And chronic diseases such as diabetes and heart disease also increase, and there usually is more obesity. We often refer to some areas of town as having food deserts. You can see a Popeyes, a McDonald's, a Burger King on every corner, but you don't see any green grocery markets. And if you can find a regular grocery store, it's probably not as well stocked as in other parts of town. And often difficult to get to because you don't have access. You may not have a car. The bus line doesn't run where you need to go, even if you had the money to be able to afford the food once you got there. How does improving the health of those influence the health of the community? Curbing chronic diseases improves your community's economic profile. Healthy people can work, and they use less medical resources. Curbing the spread of infectious diseases is also a priority and minimizes outbreaks that put the most vulnerable at risk. Natural disasters often create opportunity for disease spread. We can look at a lot of our third world countries where they don't have any access to fresh drinking water. The water becomes contaminated, and there's huge outbreaks of cholera, as one example. Efforts to improve community health. You can see a lot of cities across the country trying to create more walking and bike trails, access to healthy food at reasonable prices, playgrounds that are safe with good equipment, accessible health services, schools, places of employment, affordable housing, and education, health fairs, advertising the risks of tobacco use, for one example. And again, back to our age-old question, how do you prioritize care in a disaster? You can look at a couple of sources. There's many, many out there. The American Medical Association looks at change in quality of life, the likelihood and duration of the benefit, the urgency of need, amount of resources required. And the HRQ on quality looks at patient need, potential to return to baseline state, overall resources needed by the patient, age and functional assessments, and underlying health prognosis. And what about at-risk populations? Well, they're less likely to benefit from all these wonderful resources. Their benefit duration is often the shortest. They do require the most resources. It's very hard for them to go back to baseline. They often have poor functional assessments, underlying health issues, lowest functional assessments, and age will be mostly elderly, and therefore have often the least or poorest prognosis. So that ends part 1 of our vulnerable populations examination, and we'll look forward to part 2.